Right, it's 12 o'clock. Hi, everyone. I'm Mohammed, one of the trauma fellows at Pfizer. I have one interesting case to present. The title says like one stab, many holes. We'll start talking about two stab wounds and then we'll go from there. So the objective of this talk is to evaluate and manage abdominal stab wounds, and as well as to manage vascular injuries associated with stab wounds. So this patient is a 45-year-old male who EMS reported that he had a single stab wound to the anterior torso and one stab wound to the posterior torso. On assessment, patient vital signs, he was hypotensive with normal heart rate in the 60s, and his GCS at that point was 15. His systolic was in the 90s when they reported it. On arrival, the patient primary survey is as follows. The airway was patent. He was able to protect his airways. He had bilateral breath sounds, and his heart rate was in the 70s. Systolic blood pressure was in the 80s. He did have palpable distal pulses, and his GCS has been 15. So on exposure of the patient and secondary assessment, patient did have a single stab wound. It measured about 2 centimeters in the right hemi-abdomen, just above the umbilicus. And there was like a smaller stab wound in the mid-back, kind of higher up between the scapulae. On exam, he did have a right lower quadrant focal peritonitis. We did obtain a quick chest X-ray just to evaluate and see if there is any pneumothorax in the posterior stab wound, and there was none. So how would you proceed with this presentation? So I would open this to the panel. All right, so at this point, I mean, whether like would you proceed for the operating room, do a DPL, do a fast exam?
Dr. Mohammed, you can call on people to comment. I think maybe we can just, the ones that want to comment, we can just raise our hands in the chat, and then you can call on us. Is that?
Sure. All right, go ahead.
Okay, well, so he's awake. He's moving all 4 extremities. Is that right?
Correct.
Yes. And so in this case, I would put an IV in, and blood pressure of 80. It's low, but for somebody at that age, if he's otherwise alert, it's probably okay to do a CT scan just because he has that wound in the posterior chest, and I'd want to evaluate that to see if there's a vascular injury. It's near the midline on the right side, so he could have a mediastinal injury, or if not a pneumothorax. Apparently he doesn't have a pneumothorax. The chest X-ray, if it was an upright film, I'd want to sort of, apparently there was no pneumoperitoneum, otherwise you would have said so. Right, so there was no pneumoperitoneum. You can do that, and just because he has a second stab wound, and if he does have peritonitis, he likely will need a laparotomy or at least a laparoscopy to explore the abdomen to see if there's penetration of the peritoneal space. So I would either consider going to CT first, or perhaps doing a laparoscopy.
Thank you. Let's see who else here. Dr. Collette, do you have anything to add here?
Yes, I agree also to Undrak. If the patient is stable, although the patients have the peritonitis, I think the patients need to go to make a image exam to check the lesions, to show inclusive in the ED to think about what to do with the approach. I can approach this sometimes the patients with stab wounds in the abdominal wall in the midline with a laparoscopy and treat with the laparoscopy. But I think it's important to know if there is an hematoma. Sometimes there is a hematoma in the near the aorta or near the cava. So sometimes it may be difficult to correct or to use laparoscopy. In the chest, you have injuries on the back, maybe in the chest, maybe penetrating in the cavity or pleural cavity or in the abdominal cavity or in the hepatoperitoneal area. So if the patient is stable, sometimes it's tamponade. So I think it's important to see what is happening with this injury. So I think it is important to make a angio CT, chest and abdominal, to see if there is a vessel injuries or other injuries. Sometimes the injury is tamponade and there is blending, and it can blending sometimes later, and then you're missing something. I think these patients need to go to image exams, stable. If it become unstable, they go to a laparotomy, and sometimes maybe come to a pericardial window, and so other injuries, maybe injuries by the back. Okay.
Right.
You can ask Dr. Cassim is here. Dr. Cassim, you can tell us, and then you call all the other people to comment after you, please.
Good morning. Good morning. So I have a slight different take on the management of this case from the two previous speakers. This patient is hypotensive and tachycardic. So the first thing I would like to determine, is it a single cavity stab wound or is it two cavity stab wound, one in the abdomen and another in the chest? Of the two, I would be more concerned of the one in the back, strangely enough, because that's where the vital structures are, where you can exsanguinate from, such as the thoracic aorta. It looks like from reading of the chest x-ray that you did, you didn't see any evidence of that. And also I would check pulses on both upper extremity and measurement of blood pressure on both upper extremity to make sure they're equal. I'm looking for evidence to rule out something much more sinister in the thoracic cavity. And as far as the abdominal cavity is concerned, I certainly would not do laparoscopy. As soon as you do laparoscopy, his blood pressure is going to crash, and I would be afraid of that. I would also would not send the patient for CT at this moment, having ruled out something sinister in the chest. I think I would be more inclined to go for laparotomy on this patient. But then you have master surgeons like Dr. Foley, who is exceptionally good with laparoscopy, and he might do otherwise. So I think I would be concerned about his status being hypovolemic, hypotensive, tachycardic, and I need to get him to the operating room. But I do want to rule out that there's nothing scary going on in the chest, such as injury to the thoracic aorta. That's what I am thinking at this moment.
Thank you. Anyone else want to add anything
Dr.
before we move on?
Hoffman is here. Dr. Hoffman?
Yes, thank you. But I joined a few minutes later, so I really didn't hear the presentation of the case. So I think I need to pass. Thank you.
Then we have Dr. Linen.
We can ask Dr. Marta Chiotis. You can comment.
Dr. Martha, where is
Good
she?
morning, everybody. I wasn't
Good morning.
able to join early, so I missed the presentation of the case.
Okay.
All right, so all right. I will advance with this case. So just to wrap up for the people who
Dr. Mohammed, would you like me to moderate for you?
I would appreciate that, Dr. Qasim.
Okay. All right.
Thank you.
So we have, is there any other speaker who would like to speak and contribute to this case? Or we can move on? Okay, we'll move on. Dr. Mohammed, carry on.
Okay, so this is just a wrap up of the case. Basically, two stab wounds, one to the posterior mid back and one to the abdomen, and patient had like a right focal peritonitis in the right lower quadrant. So we went to the operating room. At this point, we started like transfusion, started with whole blood and then products, RBCs and platelets, and FFPs. Patient was taken to the OR. We proceeded at this point because we got the chest X-ray. We added a fast exam to it, and we had low suspicious for like an injury in the thoracic cavity. So our suspicious was to go to the abdomen. So we did an exploratory laparotomy. We found small bowel injuries, like two adjacent segment of small bowel, had like 4 injuries likely through and through, as well as some mesenteric injuries. At that point, we did notice that the patient had some like a zone 1 retroperitoneal hematoma, as we were like evaluating the 4 quadrants of the abdomen and the retroperitoneal hematoma zones. It appeared as a venous bleed. So how would you proceed at this point, given the information above?
Dr. Harshman, would you like to chime in now?
Sure. Well, you have a zone 1 retroperitoneal hematoma you need to explore. The question is how you're going to explore, depends on the location, if it's high or low, above the transverse mesocolon or not. So I imagine based on the picture of where the wound was, it will be a lower part. So different ways to explore this is you suspect it's a venous bleed is to do a Cattell maneuver, essentially displace the whole right colon to the left side and access the IVC that way. If you are suspected a vascular injury, again depends on the location, but in this location where I suspect it will probably be at the root of the mesentery and approach the aorta that way. I wouldn't go over the big hematoma. I would try to get proximal and distal control and go from there. I don't think that this will merit a Mattox maneuver based on the presumed location. If it's really very high, yes, you need to do a Mattox maneuver and get control of the aorta much higher. Thank you.
Mohammed, why don't you explain where the hematoma was so people know?
So the hematoma was in the lower abdomen. It was at the area of like around like L3, L4, kind of like the bifurcations of the aorta.
So in that case, you need to get control of both iliacs too at the same time. So again, so probably I would get proximal control transmesenteric in the upper abdomen to get proximal control of the aorta there. And after that, find based on the location of the hematoma, which will be the easiest way to get control of the iliacs in the pelvis. And I will get venous and arterial control before jumping into the hematoma. Thank you.
Dr. Marta, would you like to contribute now?
Hi. How is the patient in the OR? Because that's gonna make me change my approach to try to control first the bleeding and then contaminations, or try to do some damage control surgery. So I need to know how the patient is doing in the OR.
So at this point, the patient was requiring blood transfusion to maintain his blood pressure.
Okay, so I will change my approach to go directly to the hematoma to exploring the retroperitoneum from the left side probably, and having control proximal and distal. Maybe you can use a sponge or some other way to make compression of the aorta supramesocholic, and try to explore what is the cause of the bleeding, if it is the aorta or is the cava, and forget all the other injuries in the small bowel until you have control of the thing that is killing the patient.
Thank you. Dr. Coley, would you like to tell us what you would do?
I agree with all the comments. In this patient, so the great problem is maybe have injuries on the arterial, aorta, iliac arteries, and branches, and we have injuries of the veins. So it's sometimes very difficult to control the bleeding from the veins too. So I think these patients need to make initialmente make a aorta control of the proximal aorta control. It can be, if it is near the bifurcation, it can go near the duodenum, it can be control the aorta. Then you can go to the iliac artery near the femoral artery, or by the abdomen near the ischiopubic area. You can go to make control the iliac artery, and then you go to approach the hematoma. You can, in these situations, the midline, you can go through directly through the hematoma, maybe not explore column by the right, maybe the sigmoid put the left on the right. So you can open directly the midline of the mesentery and the head peritoneal area, and then you can approach the injuries. Sometimes if you have, I don't have here, but if you have a reboa, sometimes it's interesting to put a reboa in the situation and insufflation the reboa, and then you can approach. So I think you can put a reboa in the vein and the artery to try to control the hemorrhage. Today it's possible in some trauma centers, but in Brazil you don't have. But I think if you have, I think it's very important in these situations to explore this area to put reboa. That's the way that I think.
Dr. Untrack?
Yeah, so then the hematoma is in the lower abdomen. Do you think it's arterial or venous? I mean, is it expanding?
So at that point, it was like mostly like venous blood at that point. So we had like a suspicious of cava injury.
Okay, cava, right? Because that makes a difference. If you thought it was arterial, I agree with Dr. Pillay. The quickest way is to treat it the way you would a ruptured abdominal aortic aneurysm. Take down the ligament of Treitz, get control of the aorta, just distal, just inferior to the pancreas, and then you can open the peritoneum, the retroperitoneum directly over the aorta, and then you have control, and you can deal, get distal control as well, and then deal with the injury. And in this case, if you think it's venous and you can see where there should be a rent in the peritoneum, then like any vena cava stab wound, you can put 2 sponge sticks and isolate the injury, and then repair it. And then you have to be wary of probably a posterior wound as well. So I would consider it that way. doing it directly, or you can, as has been said, you can do the Cattell maneuver that would expose the entire retroperitoneum, both to the aorta and the vena cava, and you can proceed from there. But either one, and then as Dr. Marta said, I would deal with the bowel injuries last.
Thank you. Dr. Lenin, were you the staff man involved in this case?
Yeah, I should probably stay out of it then. Yeah, I mean, there was a large.
Would you like to say something?
Well, I mean, there was a large zone 1 hematoma extending out of the pelvis, up the abdomen. So, and it was, dark blood was coming out, but based on the extent of the hematoma, we were also suspicious for arterial injury. So.
Dr. Mohammed, was this patient still hypotensive, requiring a lot of transfusion while you're doing all this?
Yes, patient was requiring like continuous transfusion, almost like until toward the end of the case.
In my opinion, I prefer Dr. Coley's approach the most. When a patient is hypotensive, you don't have much time to fool around doing excess maneuvers. You want to get control of the bleeding. Of all the methodologies everybody mentioned, Riboa seems to be most useful method that I can think of. But like Dr. Coley says, a lot of institutions don't have that and don't have the expertise for that. Then you have to go to the old-fashioned method, which is take down the ligament of Treitz, mobilize the duodenum, and approach the abdominal aorta there. And while you're doing there, you control of the venous bleeding with sponge stick. I think a couple of weeks ago, somebody even thought of putting a balloon catheter in the IVC, which something to think about in a case like this. Would you like to carry on, Dr. Mohammed?
If I may, Dr. Kasim, a few comments about all of this. Is the injury in the aorta is lower, which appears to be. You don't need the incision taking out the Treitz and mobilizing the duodenum is to get control of the suprarenal aorta for a ruptured AAA. In this case, probably the aorta can be approached much lower and it's a much faster approach. The other thing is that I am part, and I cannot claim credit for this, I am part of a working group that we are trying to come with some practice management guidelines about the use of Riboa. So we did an extensive review of the literature. And I have to say that the literature is lacking. The quality of the evidence is in generally very poor. And if we take into consideration the evidence that is published, it looks, again, we are working still on this, but it will be a conditional recommendation against Riboa, because patients that we do Riboa appear to have a worse outcome, which is very counterintuitive. But this is what the evidence showed. What probably will be one of the recommendations is that Riboa should be used only in select centers where you can do a prospective randomized study, because many of the studies don't match the controls. There are many studies that are in general very, very poor. So the only case that appears to be a benefit is patient who you predict that they will have a hemorrhagic obstetric hemorrhage for placenta accreta or syncreta, where you preemptively position the Riboa. But in all the other cases, appears that direct control is better. Again, this might be proven completely opposite with better quality of evidence. But with the evidence that is available so far, That appears to be the case. So considering that Reboa is not accessible in all places, and in some places is even is accessible, is very expensive, I will use a word of caution about the use of Reboa. Thank you.
Thank you for that.
All right. So what we did is we mobilized the right colon. We also like all the way to the level of the hematoma, just around the IVC. We went above the hematoma, also exposed the IVC above the hematoma, the level of the hematoma. And our plan was to access the hematoma. We did as well mobilize the colon on the left side as well to the level of the aorta, because it was like very distal to the root of the aorta, and exposed like the proximal part of the aorta. We did access the we visualized like the iliac over like the iliac arteries, but we did not open the hematoma at that point. We opened the hematoma from the right side over the IVC, and we found an injury to the IVC that was controlled by applying a clamp above and then pressure distal, and we were able to place like Alice clamps to control the IVC at that point. When we were like mobilizing like the controlling like the IVC and mobilizing the iliac, then we identified an injury to the anterior surface of the right common iliac artery, and that's when we applied like our aortic clamp, and we did control the left common iliac. So the injury of the iliac was just above like the area where like it's marked in that picture. So how would you proceed with these injuries to repair them?
I'll go first. This is one of those injuries Dr. Dimitriades talks about, because he's had few cases in his career. And he says that when you see something like this, just behind the artery, and the visibility is not as clear as that, you may have to sacrifice the right common iliac, and underneath is where the injury is. So you get a direct visualization of the left common iliac, and you can suture ligate, suture repair it. And if you can't do that, then you may have to mobilize extensively to get at it. And I think the trick is that you need to keep in mind that it is okay to cut across the right common iliac artery to get to the injury site so you can repair it prudently. So having said that, I will now move on to Dr. Muntrak. You get a first shot at this. How would you deal with this, Dr. Muntrak?
Yes. So once you had control, first of all, the vena cava, was the injury just anterior? Was it through the posterior wall or just anterior?
It was anterior.
Okay, and then in the iliac artery, I'm guessing it was tangential. So it was one wound along the superior surface and then into the inferior vena cava.
So the wound was, it went from the anterior iliac through the posterior into the IVC, but it did tore the IVC more. So the IVC had like a 1 centimeter injury on the anterior medial wall. So just kind of that area, the junction.
Right. So, you know, the worry is that he would develop an arteriovenous fistula. So the vena cava, you can repair, just sew it up. That part is straightforward. For the for the iliac artery, you know, if you were you in the hybrid room?
No, we're not in the hybrid room, but we did have our vascular colleagues join us at this point of the procedure.
Yeah, I would think for the you know, now I don't do this, but I think I would ask the vascular guys, probably for the iliac artery, the most reasonable way to prevent a fistula is to put the stent in the common iliac. But I would ask them about that. Otherwise, I would just repair it to do the best and, you know, hope for the best. Repair it primarily.
Dr. Coley?
Okay. I think it's a stab wound. It's not a gunshot wound. So I think it's important that sometimes if you have space to repair the vena cava, inferior vena cava, you can maybe a primary repair of the vena cava in this position, surgery. You may be sure that you don't have injuries on the back of the vena cava. Sometimes it's a problem. But I think it's injuries you can put a clamp and then suture. Sometimes it's behind the iliac artery. The iliac artery is cut by the knife or the stab. So I think you can increase the stab sometimes, suture the cava, and then maybe primary repair of the iliac artery. And sometimes you can put something to prevent arteriovenosa fistula, but it's very easy. If it's different, if it was a gunshot wound, you can resect some parts of the iliac artery to repair and put a stent or a graft. I think it is not a problem. You can go by this way, and you can maybe primary repair of all the artery and the vein in this situation. If you have trouble, you can maybe ligate the iliac artery, and then you can go by an extra anatomical insert graft for the iliac artery to iliac artery, or femoral artery to femoral artery on the other side, and we can maybe continue the circulation. I think in this position, the patient needs a primary repair and maybe enough. But if you have a gunshot wound, sometimes maybe another techniques to repair. Can ligate, tie the artery, and then put extra anatomical graft. That's the way I go. I think in this case, I go to primary repair.
Dr. Hartman?
So a few things. Patients with this type of injuries might not bleed because they quickly develop an AV fistula. They have clot around and the AV fistula. Some of them might present with higher output cardiac failure because of the degree of the AV fistula, but this patient did not. So that helps you initially until you get control of the bleeding. One problem that you might find with the IVC, with the clamps, is that you might get back bleeding from the lumbars. So first, let me backtrack. So if I'm going to repair this and I'm going to put clamps, I ask anesthesia to give 5,000 units of heparin IV. And after that, I will put the clamps. But many times when you start dissecting, after even you put the clamps, you get the back bleeding from the IVC, from the lumbars. And what I personally found that is useful in those cases is just plain simple digital pressure. Put your fingers on top of the IVC or the iliac and press one side of each side of the injury, and that will usually be enough to control the bleeding and allow to repair, except that you are losing control of one hand. You have to get somebody else to do the pressure there rather than moving the clamps. I completely agree with Dr. Collet. This is a stab wound, it's not a gunshot wound. So usually the artery, you should be able to repair primarily. And after that, repair the vein also primarily. I think that's it. I don't have too many other tricks that I can offer. Thank you.
Dr. Marta, are you still there? Are you with us? No. Okay, I changed my mind now that I get the picture, the actual picture of what we're talking about here. I think I would manage it in the following way. I would go ahead and sacrifice the iliac artery, cut across the injury, repair the iliac vein, and then insert a argyle shunt and get out. Because the patient is hypotensive, he's requiring a lot of blood transfusion. I think I will do a damage control surgery. And that's what I would do first. I would not do anything to the iliac artery, mainly repair the iliac, left common iliac vein or IVC, wherever this injury is. And I would shunt it and get out as soon as possible. We have Dr. Kaufman in attendance. Maybe she would like to chime in. No, she's not there. Go ahead, Dr. Mohamed. What did you do?
All right. So as we were repairing the IVC injury, we had called our colleagues from vascular just because of the proximity of the injury to the bifurcation of the aorta, and they came in. What they did is they did harvest a GSV from the groin, and they used it as a patch. So they did repair the posterior area of the iliac artery and put a patch to repair the anterior surface of the common iliac. And at that point, the patient had received a total of like 1 whole blood, 11 units of PRBCs, 11 of FFPs, 2 platelets, and 2 of cryo. He did, at that point, he did respond to the transfusions. He was not requiring any additional transfusions. So the question was, what do we do to the small intestinal injuries? Would we do an anastomosis or just do a temporary closure and send the patient to the ICU?
Dr. Hartman, you can go first.
Okay, I am lazy. I want to get out. I staple the bowel and get out. You don't have too much room. The patient who is massively transfused is on pressors. Do the minimal necessary and get out. And you control the bleeding, control the spillage, get out, and fight the battle another day when the patient physiologic status is better. Thank you.
Dr. Coley?
Initially, I agree of Dr. Hartman, but I think it's all depends on the condition of the patients in the survey. If the patient may become stable, normothermic, so sometimes I can maybe the anastomosis. If the patients become hypothermic, acidotic, and unstable, need some vasoactive drugs, you need to stop the injuries and then go damage control at this moment, and then go back 2 days or where the patients be stable. I think the 2 procedures is possible in the stable patient. I think if the patient was unstable, I go to damage control, don't make anastomosis. But if the patient become stable, I make the anastomosis and close if possible, to close the wall of the patient.
Dr. Untra?
Yes, I agree with that. Do you have the details about the condition of the patient? Was he hypothermic or a high lactate level, any of those things, acidotic?
He was not. No, everything was relatively within normal at that point.
Yeah, so you just have to be there. Either, in this case, I think you could do either. If you did the damage control, I don't think you could be faulted for that. And with everything else looking okay, and you have to be there to decide, I think it would be reasonable also with, you said 4 holes in the bowel, is that right?
Correct.
4 holes.
Like, within 10 centimeters.
Within, yeah, so if they lend themselves to simple primary repair, or if they're within 10 centimeters, if you might want to, depending on how it looks, resect and one bowel resection, one anastomosis, you could do that also. But you have to be there. I think either judgment is reasonable in this case.
So we just opted to leave the bowel in discontinuity and do a temporary closure because mainly for the transfusion requirements and because he was unstable during the case, but not toward the end of the case. Sent to the ICU. Before he went to the ICU, we did obtain the CT scan just to rule out like any thoracic injuries or upper abdominal from the back stab wound, and it didn't seem to track. Patient in hospital day 1 was started on DVT prophylaxis and aspirin 81. Then day 2, the patient was taken for the second look, a small bowel anastomosis. We did do an appendectomy because of the area of the anastomosis. We did place a piece of momentum in the previous case I did not mention to buttress the repair between the artery, the right common iliac artery and the IVC. We placed the vitral mesh and crossed the fascia primarily. Hospital day 9, patient was transferred to the floor, and hospital day 10, patient was on regular diet, tolerating it fine, and hospital day 13, patient was discharged home. Any additional comments or questions?
So on track, would you do a closing statement?
Sure. Well, very nice case. So I'm a little perplexed. Initially, he said he was blood at the pulse of the 60s and systolic pressure of 80. He remained non-tachycardic for the whole case. And
so even during the case, so we're not sure if he was taking any like other medications. Like even though we did clear his medication from a different facility, we did not have a good explanation why. But he was in the 70s when his systolic went to the 80s.
And 45 years old, so you don't know if but he didn't tell you that he took any medication. Yeah, that's a little that's a little unusual in this setting, but yeah, but very nice case.
Thank you, guys.
Okay. Dr. Coley, would you like to give us a summary?
Yes, I think it's very well done, the case. It's a very nice case to how to treat the injuries. Congratulations, Mohamed, for the presentation. Thank you very much for share your case with us.
Thank you.
Dr. Hodgman?
This is a very difficult case that you make it look very easy. This is a case where you should expect a very high mortality. And you guys handled this so well that it make it look like a very simple case, which is not. Congratulations. That speak to your mastery of surgery by doing this way.
Thank you.
Dr. Lenin, would you like to give us some pearls? You were the attending.
Yeah, I mean, that area is very difficult where the veins are all converging and the artery is lying over the vein. It's always very difficult. Even to get control of the venous bleeding sometimes there is very difficult. So we used Alice clamps, I mean, to control it, because even clamping the cave in that place, there's usually large lumbars that will bleed. And the artery, we could barely get a clamp proximally on this case. And, we were worried. There was actually a pretty big anterior injury in the artery, linear, like longitudinal injury down the artery. Posteriorly, the hole wasn't that big, but anteriorly it was big. So originally our plan was to just repair it primarily, but it was pretty destroyed for a long, like almost 2 centimeter segment when we got done like debriding the injury. So that's why we got the vascular team involved, because I was really a little hesitant to do a graft from the aorta to, at this point. So, but they came up with a good idea of patching it, which worked out well.
Well, sometimes you can actually do an anterior longitudinal arteriotomy to get to the posterior part from inside and repair it with running sutures. And then you can go ahead and repair the anterior either with a patch or direct repair, provided the edges are all viable and look healthy. But in this particular case, Dr. Lenin says it didn't look that healthy, so they decided to put a patch on it. I'm not sure that I would put a venous patch on it, because I have seen and heard sometimes these venous patches become aneurysmal as years go by. This is a 45-year-old man. He has another 30 years to go. And I think I would be a little hesitant to do that. I would think I would put a Gore-Tex graft or something like that. Mohammed, it was a very good case. Thank you for bringing it to our attention. And it was an exceptionally good learning case. Like Dr. Hodgman said, you made it look so easy, but I'm sure that you were sweating bullets while you were doing this. This type of injuries are always very taxing on the heart. And thank you again for showing the case how it should be dealt with.
Thank you, Dr. Kasim, also for moderating. And Dr. Ontrack, you have a question.
Yes, I just wanted to ask, so injuries in that area, are they amenable at all for endovascular treatment, or are they too close to the bifurcation, or what? Both the vena cava and the ilia. What did your vascular guy say? Or maybe you didn't have time to discuss that.
I mean, I guess these injuries can be, I mean, once you're open in the operating room and the vessel's exposed, and, I think, I'm not sure you would approach it endovascularly, but say the guy was stable with some injury there, yeah, it can be managed endovascularly. There's covered stents. Now, I don't know about the venous side. I don't know if there's still, great stents for the venous side, and the outcomes from venous stents aren't that great, but the arterial side definitely could be managed. I think if you weren't in the operating room already with the vessel in front of you.
Any other comment from anybody else?
Thank you very much.
Thank you.
Thank you. See you next week.
Truth, I very little feel. I'm told you haven't seen it in 9 years. Why? I haven't missed her part for weeks. Let me get here. Get a copy of the purchase agreement and mortgage application and other documentation. I'll be in touch. Rest. Arthur Case, you sure? That's what he said. He said his name right now. There wasn't the secretary saying it on the line. Come in. This is our line. That's right. I'm Arthur Case. Okay. And we met formally. Because you